All right, it's 8 o'clock. Thank you all for coming by for our grand rounds. This is a very special grand rounds. As many of you may know, it is Patient Safety Week. And so to highlight safety and quality throughout, we have a very special outside speaker, Dr. Tess, who will be introduced by Dr. Gopal, our Vice Chair for Quality and Safety. So I will hand it over.
Thank you so much, Lynn. Good morning, everyone. It's indeed an honor and privilege for me to introduce Dr. Anjala Tess, our grand round speaker this morning. Dr. Tess is visiting us from Beth Israel Deaconess Medical Center, where she's an associate professor of medicine with Harvard Medical School in the Division of General Internal Medicine and the section of hospital medicine. She graduated from medical school at Washington University in St. Louis, where she was inducted into the AOA Society. She subsequently completed her entire postdoctoral training in internal medicine at BI and prestigious fellowships, including the Rapkin Fellowship, as well as the Morgan-Zinsser Fellowship in the medical education at the Academy at Harvard Medical School. She was the former associate chair of education, but currently is the vice chair for quality and safety, and is also the director of the Harvard Medical School Masters in Healthcare Quality and Safety Program and director of the HMS Fellowship in Quality and Safety. She's held many hats and leadership positions in medical societies and has served as medical editors for prestigious medical journals in quality. Her publications, achievements, accolades are just too long to list, but they are numerous. Needless to say, she is passionate about this area of education quality, and we are fortunate to have her here this morning. Anjala, thank you so much for accepting our invitation, and welcome to University of Wisconsin-Madison.
Can you hear me? Great, I'm gonna remove this. Thank you so much. Thanks for the invitation. Thanks for the visit. Thanks for that kind introduction. Really looking forward to the next 40 minutes or so that we'll be spending together. And I know just from starting conversations with folks in your department that you have a lot of folks who are really passionate about quality and safety and already have really good structures in place. And so I'm hoping that what I share with you today is really more of a conversation ultimately, so I can learn a little bit more about what you're doing and how I can take some of that back as well. All right, so these are the slides about conflict of interest. My disclosures: I have no financial relationships with companies that make products that are used on or by patients. But I also have some disclaimers, which is that we have all been on this journey for a long time. For the house staff in the room, actually, if you're a member of the house staff or if, including fellows, can you raise your hand just so we can kind of see? Okay, I'm not going to call on you, don't worry. Okay. All right, great. It's about half of the live audience is house staff, which is great. So for the house staff in the room, you may not realize this, but your program directors and your leadership of your department have been thinking about quality and safety training for a long time, because it has been in the environment. And what I'm going to share with you today is what we've done at the Beth Israel Deaconess. But I put this up here to say that it's not like we figured it out or that we have all the answers. I'm going to share with you one story. Your story will be different, but I'm hoping that there are pieces that make sense or speak to you for your own environment and what you've been doing. This journey really has been almost 20 years at least for some of us in the room. So the learning objectives are straightforward, and we'll revisit these kind of as we go through. And we're going to start thinking mainly about the evolution of quality and education mandates in the US, kind of as our Act 1. I should have put in my disclaimers that I'm a theater mom. And for those of you who are in theater, you'll understand when I say we just finished a production. So we had a very intense tech week and production week. And so I sometimes will slip back into theater lingo. Just give me a little grace if I happen to do that without expectation. So let's think about this, Act 1, evolution of quality and safety education. Again, for the house staff in the room, we're talking about it. It's like nothing strange. When I went to residency, which was 30 years ago, thank you for not using the dates, Dr. Gopal, in my intro, people didn't really talk about it. It wasn't something that people did. And so the journey actually, as we start to think about it, let's think about quality and safety in healthcare itself. it turns out that there was a lot of work being done in industry, right, around safety and quality science that actually took its time to come into healthcare itself, right around 1990, to Ur is Human, Crossing the Quality Chasm, documents that you guys have heard about, come to the forefront, which then paves the way for existing entities to now actually be allowed to take responsibility and have teeth behind some of the quality and safety mandates that were happening. Thought leaders such as the Institute for Healthcare Improvement come to the forefront. Million Lives Saved initiatives start to come forward. And by 2010, you have active employers who are now basically saying to hospitals, do you have the things in place to actually provide good quality care? And we're going to grade you, and then we're going to put that up on a website for everyone to see, including your patients. And so things really started to change in healthcare between about 2000 and 2005, 2006. After that, in the 2010s, implementation science, starting to think about how you take these mandates, these now regulatory agencies that are showing up on your door, to look not only at how far apart the sprinklers are in the ceiling, and do you have OSHA requirements being met, but do you actually have good, strong safety reporting systems? And do the nurses actually know who to call in case of a specific type of emergency? What is your teamwork like? Do people feel comfortable speaking up? Really starting to look at these other areas of safety. And so implementation science brings us from that type of regulation to now, how do we think about this as a science? And now the forefront of kind of where we are now is, how do we now redefine quality? Because along the journey, we focused so much on safety and maybe timeliness and effectiveness that we forgot about patient-centered care and healthcare equity, which are actually in the original definitions from 2000. So healthcare has gone through its own kind of journey in the last 30 years. Education in quality and safety, which is here on the bottom part of the slide, was even slower, I would say. So in the 1990s, there was a small group of people who were actually doing this work up at Dartmouth, University of Missouri. Linda Hedrick, Paul Batalden are just a couple of names whose work I studied in the very beginning. Were just a few of the people who were starting to say, all this exists out there in industry, and we're starting to use it in healthcare. Why is no one teaching it? But it really took until 2003 when the core competencies were defined, systems-based practice, practice-based learning and improvement, for people to start to say, hey, now we actually need to figure out how to take this and put this into curricula. This led in 2013 to the CLEAR initiative, which I will show you a little bit more about, where we now have, instead of just the Joint Commission showing up at the front door, looking at our safety processes, the ACGME is showing up at the front door as part of CLEAR, and moving forward to understand through the AAMC, which is the organization that oversees medical schools, now finally asking about quality and safety in medical student curricula with the EPAs. And then in 2016, 17, there's actually an organization that finally pulled together the educators and the healthcare folks called an NCYCLE, National Collaborative of Learning in the Clinical Environment, to actually start to have everybody at the table together. That's not to say that the board of the ACGME doesn't include people from the American Board of Medical Specialties, or it doesn't include people from Joint Commission. It's just that was one of the first times that people got together to say, okay, what are we going to expect of people? And so there has been a similar pathway within education, but I think delayed probably by about 10 years, started by a small group to start. And so how did the clinical learning environment become the focus of the place that all this work is happening? There was an article written by David Ash, who's a health services researcher from Penn, who in 2008, where he actually looked at outcomes for maternal care and took maternal care across several years, across all the several training programs in the United States, and looked at maternal outcomes, so inpatients, and then categorized them into quartiles as far as people who had the most complications and then the least complications. And then he looked at the providers in those groups and went back to see where they trained. And it turns out if you're looking at patient complications, there's a direct correlate where you can look to see the patients who have the highest complications, let's say, you go back and look to see where their providers trained, and it groups to the same smaller group of residency programs and institutions. So here was born the idea that patient outcomes could potentially be linked to the place in which you train, which was defined further as the clinical learning environment and led to changes in the accreditation system, where we begin to think about not so much how many hours of lecture do you have as residents, but actually what is the process behind which you're being educated? How does the institution know that you're good doctors? And are you actually embedding your trainees into that learning environment so that they're learning they're learning how systems care actually takes place? But even more than that, is your system good? If you're going to train people, your system has to be good so they learn how to do it the right way. So then when they go on, they practice well. And from this was really born the whole notion of the clinical learning environment. The clinical learning environment and review then becomes the arm with which the ACGME is able to come into different institutions. I'm sure you've had visits. You're probably on your 4th visit if you haven't already had it, because I think they're in their 4th cycle, where a team of reviewers looks and feels very much like a joint commission visit, except you get a few more days notice. And they're generally educators, but also safety quality experts who show up and are taken on visits by the house staff to different clinical areas so that they can actually see what the system looks like. What does the clinical learning environment look like? They talk to nurses, they talk to physical therapists, they talk to pharmacists, they talk to the frontline house staff, everyone in between. A typical, for an institution your size, I'm not sure how long the days are. For us, it's 2.5 days. In the 2.5 days they visited us last time, they went to 37 different sites, led by chief residents and senior residents from all the different departments at our hospital. We have over 50 training programs, and they talked to pretty much every single discipline. And I'll tell you, when they finished, their conclusions were the right conclusions. Like, we knew that they got what we did well for the most part, and the places that we could improve, they actually kind of nailed it. And so they were able to flip back in a mirror. They definitely, it's not tied to accreditation right now, but they actually give a reflection back to the institution to say, hey, this is what you're doing well. You have a very good safety reporting system, but in some departments, it's not connected to the hospital. It just sits in the department and it never comes back centrally. Or you have very good procedural training, but for the frontline nurse, they actually don't know whether the resident doing the procedure in front of them is credentialed to do that procedure. Are they supposed to have an attending with them, or are they allowed to do it by themselves because they have enough experience? So they really are quite good at figuring out what wants to be done. We found every clear visit is incredibly stressful, of course. How could it not be? But for the most part, we have found it useful in what we do. And so that's actually become the way in which the institutions across the country as a whole have kind of moved forward. And similarly, the AAMC has created untrustable professional activities that the medical school, for those of you involved in medical school education, know. You have to kind of sign off on whether you think each individual trainee has met entrustability in order to have them graduate. And EPA 13 was highlighted as one as patient safety and quality. The STEP exams now include a few questions around safety and quality. And so similarly to graduate medical education, undergraduate medical education is also moving forward. And then N-Cycle, as I said, was a collaborative group. They put out a white paper which said something which felt a little crazy to a lot of people, which was that every new trainee who comes into an institution, fellow or intern / resident, should do a root cause analysis or participate in an adverse event review in their first year. Because the idea is that by doing that, you learn about the system and you actually become engaged at a much earlier stage of training. So lots of guidelines and recommendations kind of across the board. So with all of this work, you're seeing from the faculty and from the educators, lots of different curricula that are getting published left and right. This has been going on since about 2007, when people started to try to understand how to put systems-based practice and the other core competencies into place, and has really just kind of taken off since the focus has been on the clinical learning environment and curricula. And even the ACGME has done several demonstration projects across the country to go in and support. I participated in the patient safety leaders group here to go in and support individual programs in trying to engage trainees. And so the time is ripe, and there's a lot of attention being played to this nationally, as we'll see. And so the conclusion of all this work is what? The conclusion is that in order to train your residents and your fellows and even your faculty well, that this is no longer just the responsibility of the program director and the DIO, or for the residents in the room, that's the person who heads up all the GME programs at your institution, right? It used to be, you want to educate residents, it's just the program director's job, and the faculty will do some stuff, but it's really just the program directors and the core faculty. And the notion here now is that this is now a shared responsibility where frontline faculty are expected to at least, they don't necessarily have to teach it, but they have to support the culture that is required in order to have residents engage. And you need the hospital and the CQO to actually understand and take responsibility for some of this training so that trainees are actually working on real problems in the hospital and contributing to care improvement. So that's one reason that this is important. Why else is this important? So this is actually a slide that I use when I teach residents or fellows about this work, which is it's actually good for the trainees. Like, they're the ones, so who knows the hospital the best? The house staff knows. Interns, first year fellows. They know exactly what works and they know exactly what doesn't work at the institution. And they are the most expert in the physiology of the hospital, right? Nurses too, right? So having them understand the role that they play and giving them a chance to get engaged and do this work can have a profound impact on the work that we do as vice chairs of quality to understand how the hospital, our department is even doing, but it's also good for them. They can make their lives better. And for some, maybe they go on and do this for their careers. You know what? Learning quality improvement principles is just as important in improving your household, improving your lab down the road, improving your clinical practice, no matter where you end up. And so it's not just about today, but it's really lifelong skills. So what makes this so hard? Like, this should be a win-win. GME has the trainees and the hospital needs help, right? It should be a win-win, but it is challenging. And these are some of the things that you hear. Faculty have no time. Trainees have no time. There's not enough faculty with expertise. The administrative staff have no bandwidth to kind of support the projects, and there really is no curriculum. If you talk to the operational leaders in your department, the projects are too big or not meaningful. What's important to a resident isn't always actionable in a short period of time. Data can be too hard to get, and it's really hard to maintain continuity or sustainability because of the life of what a resident is like. They can't manage projects well. They just can't. They have to be in the ICU every other month. Or not every other month. Don't worry, we don't do that. They have to be in the ICU or on the wards or wherever they need to be in the ER, in a place where managing a QI project day to day is going to be hard, is what I mean. And then finally, from a department standpoint, or just from a mission, a department or a hospital mission, it doesn't always have the same value as academic endeavors, at least in the past. We're trying to change that. And then trainees, you do all this work with the trainees and then they're gone. And so they have traditionally been viewed as transient members of the community. And I would like to flip that to say that they are integral parts of our community who we need to build on. For me as an educator, it stimulates other questions. When is the right time? And this differs institution to institution. So should it start in medical school? Is that when residents or doctors should start to learn this stuff? And I'm being very doctor focused today because I work in a department, but some of these things obviously translate to other professions as well. But let me ask the house staff, how many of you, don't worry, I'm not looking. How many of you, and I'm not going to call on you, but how many of you got trained in some part of quality and safety in medical school? So before you came. Okay, good. Keep your hands up. Was it lectures only? Sorry, if it would, no, you got to do projects and stuff. Okay, great. That's awesome. All right. So a lot of places believe that medical school is too early, that students don't know enough, and that we should wait till residency. At Harvard Med School, I would say that that's probably the philosophy of the educators at Harvard Med School. They believe it's in the purview of the residents. There are some rotations, and I just started a course at the med school, and it's peppered in here or there. But this is something to think about. I would say fellowship is too late, and in practice is too late unless you're doing it because you never were taught it. But I would say starting in med school is ideal, because once you turn your eyes on to this, once you see this stuff, it's like being in the Harry Potter world. All of a sudden you see the magic. You see this whole world that's existed around you that you didn't know was there. And so I think earlier is better, but that's my bias. The other question this pushes for me is, what are we actually trying to accomplish, right? So when you have external regulation and guidelines, it's going to generate check boxes. And in a busy world where you're also trying to teach the differential diagnosis of interstitial lung disease and how to talk to a patient at the bedside, quality and safety can often end up as a checkbox, right? We covered that. We did that last year. We did that in X rotation, which is one way of looking at what we're trying to do. Ideally, you're trying to get trainees to the place where they see things differently. You want them to potentially be doing things differently, right? To me, that's one of the holy grails. But also, could you get to the place where this person is now different as a result of some of the education? And to me, the difference between this is up top, we have potential learning, but for me, some of the goal of what we're trying to accomplish is actually to change the learners and actually transform them in some way. What I'd like to do later is actually share a little with you about how we've been doing that. And so what are the right elements to accomplish some of these goals? If you're going just for learning and the checkbox, didactic training is fine. You'll see, I did put modules on there, but a lot of people say we did quality and safety training. They had to do 3 MyPath modules on it, right? That's not kind of what we're talking about, but some places do didactic training that's interactive as a way to at least start. But if we're getting to the does, which is kind of what I think we need to do, we really need to be thinking about how to integrate them, give them real event reviews, real QI projects to work on. And if we need to do simulated case review or project work, simulated project work to teach them those skills, then fine. But if we're really trying to change who they are and give them skills they can take with them, integrating them into the department, I think, again, is a win-win. We all kind of benefit. So this is what it often looks like across the country for students. There may be a lecture or a stream that peppers through different courses in their first 2 years. University of Chicago has this cool thing called the Patient Safety Horror Room, where in that first boot camp, patient safety boot camp week, they throw them into a room and there's all these things that could cause harm, and it's their job to kind of find them. It's like kind of like an escape room, you can't escape. Mock reviews of cases, we do that with some of our students, rotations or courses, and then obviously role modeling is important. You can't have the faculty member that says, don't do this or you're going to get me called out on the reporting system, right? You need good, solid role modeling to happen, or somebody who's going to scoff to say, oh, this is that QI safety mumbo jumbo. Let's just do this so we can get out of here or get onto our next case. So thinking about that for students, for residents and fellows, most people I think are up in the experience bucket. As was pointed out, it is now required that residents and fellows do some sort of patient safety and or QI project, depending on which survey you're filling out for them. But most people are up in this top box where you do lectures of some sort. They do either an individual or a QI project as a group, and then they do an adverse event review. There are rotations that you can have, and that's the path that we've taken. Or some places have actually gone to specific longitudinal tracks where the residents actually become part of an operational leadership group for the department. So Penn, for example, is a place that has done that. And then for those of you who are sitting in other fellowships and other residency programs, you then have to take what you're doing and think about how to scale it for all of GME. So if each residency program is one of these little Ps, you could just have core standards where you expect everyone to do something, or you could have a set curriculum that you make everyone go through, and then you just provide support in the divisions. And depending on the size of the organization, we do see both of these kind of across the country. I'm going to call out Rebecca Jaffe here from Jefferson. For those of you who are in this space and have few resources, which is like all of us, what she has done as DIO in her institution at Jefferson is she's basically that every year the GME office adopts 2 or 3 programs. and they come in and she incubates their training program as from a curricular standpoint. And then at the end of it, they're like ready to teach kind of on their own. And then the next year she brings in 3 more people to incubate, or 3 more programs. And then the programs that just graduated also helps. Then next year she can bring in 6, right? Because now she has 6 programs trained. And so she's done a really cool way of scaling across her whole institution. So that's generally learning objective number 1, which the story is 3 decades old. Educators are not alone anymore, but there are significant challenges, and there's quite a bit of variability in how different programs and specialties approach it. But there is a huge way in which things are growing to give people a chance to train up. And so I'm going to quickly switch to talk a little bit about how our program has done this. So to orient you a little bit, so Beth Israel Deaconess is one of 5 major medical centers affiliated with Harvard Medical School. And we are a large clinical department. We have the hospital itself is 680 beds with services. We don't have a pediatric service, but the hospital, we have a NICU, but otherwise that's the remaining of the hospital. We do have a separate but attached psychiatry hospital and a residency program there. The Department of Medicine within that is large. We have 167 residents across 3 years. And the focus on quality and safety, really, it's been part of the hospital culture for 2 decades. And in fact, some might say it was the saving grace for our institution that came very close to folding in 1998, which was ironically my junior year as a resident, as a part of one of those messy mergers in the 1990s. People have written books about it. It was pretty horrible. But quality and safety actually was one of the ways in which it gave us a mission to kind of, as an institution, to rally around. So that's kind of the culture. A lot of transparency. Our CEO would put our central line infection rate up on the internet before that was like a thing to do, and kind of upset the board. But it's part of who we are. Our department has had a M&M in place for decades. It goes back probably 50 years, and it's weekly. And we discuss cases. And then we have a QI structure in the divisions. Depending on where we are, it can be more robust than at other times. And what I'm going to share with you a little bit is the dark circle here, which is what our focus curriculum has been. I'm up here talking. This is my partner in crime, Julius Yang. He's now the vice chair of operations for our department, but we both started as young green hospitalists in the very beginning, and then became associate program directors together, which was helpful for this. But there's no way it would happen without all of these individuals, including other members of the residency leadership and our hospital quality and safety department, who've been amazing. And so this is kind of our team as a whole. But I'm going to take you back to 2001, where there was this idea of how could we bring residents into our culture so that they were learning more. And it came from leaders in our department and then in the residency leadership, but also the person who was essentially our CQO at the time, before that was a real chief quality officer, before that was a real role. And the idea was, can we bring residents in and have them learn? And so we created this thing called the Stoneman Elective, named after one of the families that had started a QI center. It was really just a name at the time. But the notion here was that we would bring together healthcare quality and GME and give them real hands-on work and allow them a window into the hospital infrastructure. So we would send them to hospital meetings as part of their work. And this is what it looked like. They got very few didactic sessions, 2 hours, essentially, or 3 hours. They get to meet with the leadership and ask all the questions they never get to ask. They would complete a real live case analysis that had come through our adverse event reporting system. And they would complete a QI project, but because we only had them for 3 weeks, we let them do just part of a project, and they sometimes would hand projects off between groups. And at the end, they would end up with a portfolio of kind of the work that they had done. And so we started, like I said, in 2001. It was elective. We had volunteer faculty. I was fortunate enough to be one of the people that got asked to help this because I was interested in curriculum development and was wondering why they were asking me to do QI as part of my job as a new hospitalist, and yet I had never been trained. Like, why is no one talking to the residents about this? So I got involved and helped structure this and served as a volunteer faculty, and it was quite successful. We, in 2006, made it mandatory. So in the beginning, it was an elective. We had up to 11 residents a year. And then in 2006, we made it required. So every resident had to do it to graduate, only one of 2 requirements. The other one was geriatrics. And I said, you know, I can't mentor 50 residents a year by myself anymore. So what are we going to do about that? So we hired a core faculty. And what that means is we took 6 faculty members, each of whom are supported 0.1 of an academic rate, FTE, for the administrators in the room. And they're asked to precept residents as they come through in groups. And so we have residents who are in groups of about 4. And because of the way our structure is, we can get 48 to 52 residents in per year, which is about our junior class, the size of our junior class. Then we had residents out there doing root cause analyses and calling the house staff on cases they might have been involved in or that they might have reported. And the interns were saying, what's going on? Like, why is this person calling me? So we realized we needed to support our interns more. And so we started mock case reviews for the interns to come in and learn and teach them some of the principles so that they wouldn't freak out when they were getting called. The seniors were saying, well, now what? You've done this with us. We want more. So we've put together an advanced QI retreat where we use lean principles and take nurses and doctors and patients and other allied health professionals, depending on the project. And we work in and for a week, we actually have one coming up in May. We take them away to a large conference room. It's not very fancy. We get Rice Krispie treats, always seems to be a hit. And we work on a real project. So right now we're trying to redesign our handoff from the ICU to the floor because so many things get dropped and it's not seamless, which makes no sense because you're literally just going through a double door. But sometimes it feels like you go through a double door and there's such a voltage drop in that patient's care that's completely disorienting for the family and the patient, right? So we're going to redesign that. So what are we going to do? We're going to take everyone, there's going to be 30 of us, go into a room. We're going to process map. We're going to do waste walks. We're going to redesign some of the standards and hopefully create a way to more seamlessly hand that patient off, including an ICU diary that the patient's family will be filling out, that we have a way to then talk to the patient about their experience, hopefully reduce some of this PTSD that happens. That's our next QI retreat. So we added that for seniors. We added a conference that happens once a month where we're able to take our outcomes that are organized by resident and not by resident, sorry, by resident group, because we went to a geographic admitting system. And so we reflect back the length of stay, let's say, or the CAUTI rate or the central line infection rate. And because the residents are always coming back to the same floor when they come back to medicine, those clinical outcomes are now owned in some way by that group of residents. I started coaching the chief residents. We created an idea system. There's a QI council that started in medicine that's now gone to the institution. And the idea is that over a long period of time, 20 years, we started to expand the work. And when we started with 4 residents our first year, some of whom are my favorites, including someone who's now I like to say this, the chief clinical officer for Google Health, which had nothing to do with me, but I like to take credit. We went to 17 residents a year, 48 residents a year, which we've continued. And now we've trained over 725 people this year will be our graduating class. We'll hit that number. So it's really made a difference. And has it made a difference in the trainees? Yes. So I would say everybody leaves with a different set of eyes. That I believe, that I know from some of the surveys that we've done. I would say that there's a large group of people at this point who go on to become quality and safety leaders at other institutions. They came in with the QI mindset, they left with skills, they quickly moved up. But then there's this other group who I would never in my wildest dreams have imagined that they would be the person doing QI. And they come back and they're like, Angela, guess what? Guess who's doing QI? It's like, this guy is doing QI. And I'll be like, really, that's amazing. But when they leave, they have kind of this new set of eyes and some skills, and they're the ones who actually know how to at least start. I'm not saying that our residents are able to run a quality enterprise, but they at least know how to at least begin and how to look and ask questions in a way that kind of helps them. And it's not for everyone, but it does seem to work. And so this is what it looks like put together: interns, juniors, seniors, and then we have people often go on to do research reports. And as I said, we have an outcomes conference, and then we have a weekly M&M, which is kind of critical to the safety culture of the group. Our practice has really been to figure out what the knowledge is, keep it small, because really they should be focusing on experience. And then we wanted to incorporate it into daily practice. I'm going to show you that in a second. and then it's really embedded in the culture and the approach. These are some of the project streams that they've worked on. And so something like Claudie may have gone through over the last couple of years, may have gone through 4 different groups, depending on what they were working on. And you'll see it's all the stuff that our department should be doing or wants to be doing anyway. One of the things I get asked is, do the residents pick or do we pick? We used to do it where the residents would pick. And then we end up with these 17 strands that we can't implement. And then we went the other way and we said, you will work on this. And depending on the topic, especially because it became a mandatory thing and no longer just for the people who really, had signed up to do it, I would get these glazed looks, right? Like, really, you want me to work on hand hygiene for 3 weeks? Are you kidding me? I knew that QI was about hand hygiene. They just didn't want to tell us before today, right? They just didn't like it. And so now what we do is a short list. So pick out of these 1 or 2 things. And some of it depends on, sometimes things need to cook. The residents will come up with a great protocol. We need to go vet it with the leadership before we can say, let's do a rollout. So then we'll bring up the next project or 2 and say, these are ready. That one's got to go cook. A month from now, that'll be ready to go. And so we're constantly moving it. It does require project management to do well. But as far as embedding into clinical work and being able to reflect outcomes, this was a change that happened simultaneous to when we went mandatory with Stoneman, which is, it used to be in my residency, I might have a team and I would be on all sorts of different floors in the emergency room down here. And one of my classmates might be practicing with his team. Julius would have his team, and he would also be all over the hospital. I understand you would need many more buildings and terminals for your hospital here, but this is what our experience was like. And so we spent a lot of our day kind of running around doing this. And so in 2006, we co-located our teams onto floors for the vast majority of their patients. They might still have some off-floor borders, but we're generally on 1 of 2 floors, more floors if you include the sub-service. And so with this, we thought that we would get great improvement in patients' perception of teamwork, but it actually didn't change, because what we realized is kind of like toddlers. The residents and the nurses were working right next to each other, but not really talking to each other, just engaging in parallel play. And so the last thing that we've done to try and improve this is actually try to create pods on our floors, and that the nurses and the doctors are trying to co-schedule. It's hard because the residents schedule patients on their teams based on the time of admission, right? Or the admitting cycle. Nurses assign patients to nurses based on the acuity of the patient, because they can't have 6 patients who are all, need a lot of assistance. So we've been working with that. This is again another brainchild of Julius's, but this is an example of something we tried to work through in one of our QI retreats with the nurses on our main floors. We have a QI dashboard that helps us understand who's at risk for DVT and getting DVTs, who has a Foley that we can maybe pull out, who's getting ready to leave. And then we've actually created structures that use this, including a morning huddle design, patient progression rounds, which is another word for case management rounds, and then a trigger system actually that pulls from this. So our rapid response team actually feeds into it and then also pulls from it. They review it if a patient is undergoing a trigger, which is again our name for rapid response. So scholarship from this has included several papers, which you can read, that have more detail about how we actually do our root cause analyses, in case that's of interest to you guys. That's the reason I'm showing it up there. But one of the things that we showed is that we were able to show that the culture for the residents had changed. So I feel that patient safety is important. They cared about it before at 94%. They cared about it after at 97%. But when we looked at, I play a role in designing or implementing it, went from 37 and 68 up to 84. I feel comfortable reporting an error was about the same. But when we actually looked at this over years, a lot of these have gone up into the 90s and stayed there. What about the fellows? Fellows often forgotten. What did you say? I forget the Lost Tribe, members of the Lost Tribe. And you guys have a lot of fellows in your department here. So what I did here is I took one of the core faculty and I said, work with me to help support the fellows. And so what we did there is we actually created these large symposia where the fellows come, and we've actually we've made it so they're mixed. So we get whoever will send their fellow, that's who we take on a given day. And in the groups, we divide them into procedural fellowships and non-procedural, and they work on cases and potential projects based on that. And so that's how we've managed the small fellowships. For the larger fellowships, I actually go to the larger fellowships and do some work with them within their own meeting times to help them move forward. And they are typically working on group projects, but some of the small fellowships like nephrology, for example, or endocrine, will actually do individual projects to make that work. So we've had challenges. I mean, just like everybody, data is a problem. We have a homegrown system that can be challenging to get data from. The pandemic added all sorts of lovely logistical challenges. I've had core faculty turnover, which has been challenging at times. Fellows need more attention, I think, because they're so busy in helping them get their projects up. Can be challenging because for us, we have 15 accredited fellowships plus more if you count non-accredited. We really do need more of a celebration, I think, as a group, which hopefully post-pandemic we can start to have larger symposia and more publications. I'll just pause briefly on this, which is to say that we have a health system science course to replicate some of the QI curriculum that we do for residents. I just finished this with a bunch of students, and again, asked them to work with ongoing QI teams as part of that work, even if it's just for 3.5 weeks, so that they can really contribute and actually learn how to use the skills instead of just sitting in a classroom and working on mock projects. And so that's really learning objective 2, which is how one academic department integrated trainees. And none of this is possible without several things for which I am most grateful. The first is support of our department chief. He's Mike Slidell, very, very supportive. He believes in quality and safety. It's one of his 4 pillars for the department. And so he's been really a great cheerleader, but also kind of helping to stand next to us and say to the divisions, like, this is something you need to care about. Our program directors, Eileen Reynolds at the time, and now Chris Smith, and the clerkship directors have been very welcoming and willing to give us learner time. My background was in curriculum development. It's what I did my education fellowships in. And the most valuable resource in medical education is time with learners. It's not the faculty, it's not the simulation center. All those things are important, but it's time with learners. We have very little face-to-face time with our trainees. The hospital quality leaders will give us the cases for our residents to review. And residents reviews get presented at our monthly, every 3-week QI committee. The residents are doing the presentations. And those results actually go all the way up through the system, even up to the board, if that's the correct path for that given case. Our residents rotate every 3 weeks. The hospital moved the QI committee meeting from every 4 weeks to match the resident schedule, because it doesn't work if the residents aren't there. And that to me was a huge win, and actually great piece of partnership. It was a gift because it really allows the residents to see themselves as contributing. Conferences, symposia, and then thinking about academic currency is all important. And so none of this would happen if we didn't have this context. That's our department. So in the last 3 or 4 minutes, actually 5 minutes, I want to share with you a little bit about the third act, which is how does this potentially lead to career opportunities for residents, but then also for faculty. And I'm going to pause here for a sec, which is to say that this is all daunting, because if you haven't had training, which most of the faculty have not, how do you actually even take a step forward? And there are lots of different things you can do. There's internal CME, there's lots of external CME courses. There are certificate programs offered by a whole host of academic centers across the country. Hopkins has one, Northwestern has one, Jefferson has one, we have one at Harvard, and there are others as well. Kaiser has one in California, there's a ton. I'm going to stop that because I could keep going. Utah has one. So there are a lot of certificate programs that require kind of some commitment, but not necessarily an entire degree. There are master's degrees from pretty much all those places I mentioned. And then there are a few fellowships in quality and safety. Sometimes they're within a specialty. So within hospital medicine, for example, you could do a hospital medicine fellowship, and it could be focused on quality and safety. I used to run a quality fellowship at Harvard that's unfortunately closing, so I can't offer that to you. But you could do more advanced, but you can also do internal. And what that means is if you have a core group of people for the faculty, for example, who are interested in quality and safety, there are a lot of resources where you could do some self-learning and then come together to actually practice the application and use yourselves as a peer group to move everyone forward. There is enough out there now. It wasn't 10 years ago, but there's enough resources out there that you could do that. And so I would encourage you to think about it. And everyone knows something that someone else doesn't know. And so peer training can actually be quite effective in both training yourselves, but also giving everyone the confidence to actually do something and change. And that type of training, no matter where you are on that trajectory, can help you move up if you're interested as a faculty member. So I would say that sitting in conferences like this as frontline faculty can hopefully help people see that just being able to support the residents in the work they do is valuable, and not scoffing when the institution says, hey, let's do this now because it might be a safer way to do something, could give you that information. But for educational leaders, operational leaders, or people who are even have their eyes on the CQO, the C-suite later on, some of these other training opportunities are there. There are, for faculty who want to become QI educators, there are more opportunities. AMA has the Health System Science Scholars Program. The AAMC offers teaching for quality. They'll come in and teach with you. QC, which is an organization I've been doing work with, runs an academy in training people how to teach QI, not training you in QI, but training you how to teach QI and patient safety. And these are all opportunities. And then of course, you're a Department of Medicine, I'm from a Department of Medicine. Apton has a ton of offerings that teach you how to teach this stuff. There's also the notion that you can publish your work. QI can be research very easily. And Dan Leffler used to be one of my patient safety core faculty and actually would help me train the fellows. And he would tell the fellows that there are 3 levels of a QI project, right? We did X because it seemed reasonable, but we actually don't know what happened, right? We have a new checklist, let's put the checklist in place, right? Right, it's useless from a research perspective, it doesn't tell you anything. There's well-intentioned, which we did X, new checklist, and audited processes to make sure that people were using our checklist. Yeah, that's great, but it doesn't quite hit there. The gold standard is we did X, and then we looked at a clinical outcome that we thought would be affected by X. We did a checklist to remove Foley catheters, and then we looked at the CAUTI rates on our floors, and they went down. Additionally, we assessed process measures around the implementation of X, meaning that we looked to see if people were actually using our checklist. And then we did some other statistical analysis to understand, was it something about the patients or whatnot. The work he used to say, which I agree with, is the work to get from well-intentioned to gold standard is actually not that far. The hardest part of QI is not the statistics and the research. Some of it's the data, but most of it's actually getting people to do things differently. You're already doing that in number 2. Why not do the extra 10 to 15% and get to number 3? Which I always thought was profound advice. And that's why I'm sharing it with you, which is that you can get here. If you're already doing the QI, operational QI, the active work, do a little bit more and potentially be able to show this. The other piece about QI research is that ideally you want to be in the middle of this Venn diagram. This is also a Dan Leffler slide, where what you're trying to intervene on is important. It's novel in some way if you can, and it's feasible, meaning you can actually pull it off. Sometimes we come up with novel things that you can't do, or you come up with important things, but it's not feasible to do and it's not novel. You're not going to publish instituting something that has already been worked out and is known to be an issue nationally, and people have figured out how to do it, right? But you could take a checklist of some sort, let's say, and has it been shown in your population? So trying to make sure that people are on contraception if they're of childbearing age when they're taking dangerous medications has been done a little bit, right? Trying to get people of a certain age into contraception, making sure it's being done right, maybe done well in primary care, but maybe it hasn't been done in rheumatology, or maybe it's been done in rheumatology, it has been, but it hasn't been done in hepatology. And so thinking about how you can apply it to your population is a valuable thing to do. And generally, when you do these things, you can submit to general journals if it's really novel, but a lot of QI has been worked out in the general in general QI and quality and safety journals. The specialty journals have not done this enough yet, and you could potentially get your stuff published there. Go to specialty conferences, but just be aware that there are specific criteria, and you have to think through the IRB, which maybe is native to your institution. QI education is research. I showed you all these papers, right, where people are doing this work. Each of these 3 papers that I'm putting back up not to show you what I've published, but to show you that there are 3 different types of educational research. So if you move forward and do it in your own specialty, you could do this. So this was a descriptive paper, it was our first one. This is what our QI elective is rather. And we had kind of student reactions. I also had been doing some knowledge assessments. So we had some knowledge assessment. Great. This one, we added the operational piece to it. So we did another descriptive piece, but this is where I put in the culture of change data to show that you could show culture of change. And then this one is on the process of how we do involve residents in case review. It's the same work that we've been doing, just at different stages. And depending on where you are and where you're at, you can generate scholarship from the education that you're doing. And it doesn't need to be another whole educational research project. It can be what you're doing already. And if we're going to start to think about what is novel, let's talk about what are the new areas of interest that people are looking for papers in and looking for presentations in, right? Patient-centeredness. We kind of have like where's the patient, right? So think about like, how are you going to incorporate patient-centeredness into your training? Specifically thinking about how you can partner with patients to actually innovate your systems and change your systems. How can you incorporate patient family advisory councils? This is an example of simulation and anesthesia that was really focused on patient-centeredness. So this is a space that you could go into with your QI projects that you're planning to do anyway. Involve the patients in some way, not just so you can publish it because it's the right thing to do. Here's another one, health equity, right? Look at all the different things that you could potentially be doing. This is one that I'm trying to think through right now, which is, you know, that bucket of patient-related factors when we review cases? How can we actually learn more about that? That's an equity issue. Those are social determinants of health. And thinking about any new innovation that you put into place with an inclusive eye. And then lastly, burnout. Burnout, one of the biggest threats to patient safety right now is all provider burnout. And thinking about how can we not just do regular old teamwork training, which has been done 100 times, 1,000 times maybe, but how do we change our teamwork training to look out for burnout in our peers? That's a new area that people haven't thought through enough. So this is learning objective number 3, and I'm just going to end with the denouement, I guess, from theater, which is culture. And that is, if you're going to engage your providers, any culture relies on its stories, its heroes, rituals, language, values, norms, and artifacts as a way to build culture. In our department, this is what our norms are and who our heroes are, right? Our heroes are our residents and our chief resident. Our language is, we don't use error anymore. We try to use event. RL6, which is our reporting system, is now a verb. Norms, reporting is encouraged. Every resident's expected to do STOMA. And that this is how we have kind of changed our culture through structure and process. And I trained in an organization where I ran around doing practice. The hospital looked at measures that was blind to me. They would look at it, they would design new policies, protocol, and then they would tell me what to do. And we've kind of changed ourselves from this passive learning model to something's a little bit more active, where I'm working alongside, as a resident, I would be working alongside my nurses. I would actually be participating and designing the policies so that it becomes an active learning model in the way we do things. And so with that, I'm going to stop. I'm sorry for running 5 minutes over.
Great. Thank you so much for the talk. Really impactful. And I wanted to follow up on that scholarship piece because I think it is a missed opportunity, not just for academic credit, but for dissemination of the work and sharing it with others. I was amused by your next project, which is the ICU handoff, because that has been an issue since I was a resident. And so do you envision after the completion of that project that you're going to have a product to disseminate the work that you do?
Yeah, so the goal, once we get our principles aligned, which is the hard part, the goal is to actually have the residents, the nurses, the physical therapists, social workers, the chaplain, all actually design I don't know what it's going to be because we design it real time, but I'm imagining it might be some sort of handoff tool, or it might be some sort of document, or it might be some sort of metric that we're able to put in place to actually make sure the patient's being involved, that physical therapy isn't starting from scratch, that there is less of a voltage drop. So yes, we always design towards some sort of deliverable. And then how we'll disseminate it. So we have to talk about it with all the stakeholders at our hospital, and then probably do a poster somewhere if we're able to implement it.
Questions? Hey, Dr. Trowbridge.
That was so inspirational, and I just loved the vision over time. I think that helps us to move forward. I want you to, could you comment on your rituals, specifically your weekly M&M? What do you do there? Who is included in that? I think that's something we kind of dropped a while ago in that form.
So we do a single case. We don't, some people do a bunch of cases. We do a single case. It's run by the chief resident, who spend a few weeks preparing it. There are 4 columns. I coach them through them, but there are 4 columns. The first is what actually happened medically and what can we learn medically. The second column is what is the quality and safety learning from the from the case itself. Was it a diagnostic delay? Was it a communication failure? How can we actually think about it from a QI and safety science perspective? Then we actually also use it as an opportunity to teach local systems and processes. So we remind people that this is how you call a code stroke, and this is what they're going to be looking for. Or here's a reminder that if you're dealing with a patient who's having ethical issues, these are the different things that you're going to want to be thinking about yourselves as you prepare to manage that patient, whatever it may be. And then we also then focus on what potential fixes could be. The goal is not to come up with the fixes. You cannot come up with a good fix in front of 100 people. But it is really just to get people thinking and talking about cases and learning. We do a lot of work around clinical reasoning in the case itself, but we always try to link it back to some sort of safety science. It's our best attended conference. And we have house staff, and now that we're partially virtual, we have people from all over our community. But it's run by the chiefs and it's done every week.
Thank you, Angela. We have a couple of questions online as well. Dr. Barzi asks, cultural transformation for quality and safety have thoughtfully occurred at the hospital, department, and unit levels, but these still seem to be redundant or siloed and not well integrated, which can be challenging. What strategies can actually help to make this a one process across the institution?
So I think that's where you go back to that slide where it says standards and processes, where you actually come to an understanding of why you're doing certain things that you're doing, and come up with a set of, so for example, what I just told you. So having those 4 pillars in every M&M discussion and how we set up the case means that we address those 4 elements. Similarly, you could have set elements for every project that you do, that maybe you classify it into one of the 6 areas of equity and safety that came out of the IOM report. Or maybe you're actually looking at what level of learner, what level of provider it's involved, but that you have a classification scheme that you use for your projects and that you use for your safety reviews. And then you have a set process to bring people together to discuss them. So one of the things we're going to try to do is do a QI council across our department, which used to exist, but hasn't existed. And I think we've become very siloed within our department. For us, we have a collaborative type council like that across the departments already at the hospital level that's sponsored by our CMO. And so that for us, that's where a lot of that learning takes place. So standards and process is my answer to that.
Good, thank you. Dr. Sancha Ferguson asked, thank you for a wonderful talk. Can you talk about how you have incorporated health equity into your QI training curriculum? Is this similar to how it's embedded into the operations work for your department?
Yeah, so we're actually, for the residents where we started, we're struggling because we have a lot of missingness of data with our equity work. And we're working on trying to get our data more clear because our patients' demographics aren't always where we need them to be able to do the work cleanly. So for the residents, because I wanted to start early, we've actually been focusing on low English proficiency patients and patients with disability. And that's where some of their projects have been. And so, for example, trying to figure out how to bring video interpretation into the resident clinic and into the resident practice has been one thing that we've been doing. And so I've started there, but hopefully once the missingness of data gets better, then we'll be able to actually start looking at projects. Our outpatient practice does a lot with access to care for different ethnicities because they were able to clear up their data. We're just starting. We have not gotten, we're scratching the surface, if that.
Great. Thank you so much for this, Ann Sheehy, hospital medicine. You know, watching this, it's amazing the body of work you've done, and it makes me think of my work in the policy sphere. So it's sort of implementing, you know, knowledge of the system in which care needs to be delivered in, and getting that embedded into educational programs. I think the barrier that I've heard is a very real one. It's bandwidth. You know, this sometimes gets tacked on to all the other duties the residents have or the medical students have. How did you overcome those barriers in implementing this program?
By making sure that the Stoneman rotation, so, you know, M&M and all those types of things, that just happens in the environment, but the Stoneman rotation is the first thing that goes into the resident schedule. I was telling folks at dinner last night that I ran the resident schedule and I was associate program director for 13 years. And one of the reasons I held on to that job was so that I could make sure that Stoneman was the first thing that got scheduled. And and everything else gets scheduled around it. But that was a choice, right? That's a choice around structure, and it's a choice around process. We committed to that in our process for scheduling. And unless you link all the stuff you're trying to do to a structure and to a process, it's not gonna happen. It will happen when people mean to do the right thing. But when things get busy and stuff falls apart, it's not gonna happen. So if you can hardwire it, it's more likely to happen. And that's what we did.
Well, thank you for really an inspiring discussion. And we'll look forward to a lot of the discussions throughout the day.
Thank
So
you
thank
so
you.
much for the invitation.